Welcome to the 6th training and logistic meetings. Here we discuss all the preparations and how to make effective training in Tanzania during the medical mission. And in that plan, we are doing all the virtual training beforehand. So by the time we get there, we are going to have great experience and great training with all our colleagues in Tanzania. So I want to welcome everybody in the meetings, and today is June 24th at 11:07 or 8 now. So we do have almost, are you in the formulas? Oh, you're double. Okay, so we have almost like 10 people are here, so we're gonna start the meeting. So thank you very much. We're gonna try to make it as quick as we can, give you updates, and then finish up what we planned for today under an hour. So, because some people have to go back to work. Since some of us are on the break, so yeah, Taka did remind me to make it short, quick, because she's at work. So we hope that no baby is misbehaving in the emergency room, so she can attend the whole meeting. And thank you, Dr. Akida, for being here. Miss Emily, Hunter, where's Bree? No, she's in Mexico, remember? Probably she might have a problem. And of course, Mr. Raymond there and Mr. Prank. So thank you, everybody, for being here. I am going to start sharing my screen if anybody has any questions for today. Any questions? Going once? No. Okay. Let me start sharing the screen so we can go through the agenda. Yeah, check the chat. I think she sent a message. Does everybody see my full screen with the agenda for today?
Yes.
Okay, so we are going to go give you a little background of when we are with the global training, and then we're going to review the June 10th of the meetings, and then we're going to discuss what we need to do today. So we have, we are privileged and blessed to have Mr. Raymond to come and give us a little bit of background of what he does with the patient transfer, which is related to what Mr. Mbinda has sent information about transport and stuff. So we can learn and gain our knowledge in that area. And then I'm going to open the meeting for any questions or stuff. And then, so first of all, before I go to the training, I want to acknowledge and thank Mr. Mbinda for all your hard work. This was the most response I received and feedback for what we had questions on the 10th. And he provided a lot of answers that we need for us logistically to plan for that training. So thank you very much, and I appreciate that. And Dr. Akida for sending the list of the people from Mwananyamala. We appreciate you, and thank you very much for being here. Okay, so let's go back to the global training. So far we still have the 3, but then we have more training coming starting next week. So we have had already the neonatal health resuscitation, we have the neonatal temperature, and then we have ventilation. And then now we're gonna have next week, June 30th and July 14th, fetal monitoring. And then we do have all those people already working in the PowerPoint and the case study. And I wanna thank ahead of time, Mr. Jafari from Muhimbili for providing an excellent 3 case studies, so which we're going to enjoy and discuss during those days. And then Dr. Emma Mugeri is going to be doing the part of the presentation. Professor Michelle Brown is going to do also part of the presentation. And Ms. Nema Minja also, she is going to come and explain part of these interventions for nurses. So those classes are going to be 2 of them, as I said, June 30th and July 14th. And then we're going to have postpartum hemorrhage. Almost the facilitators are almost similar to those both groups because they both happen to labor and delivery patients and postpartum patients who the players are the same. So we're going to try to tag team between. So July month, it might be all the OB part. And then we're going to go back to for August to do again some of the babies and the transfer stuff. So more topics, again, we're still working on the obstetric emergencies and anesthesia that Dr. Gwen is still working on it. We're going to figure out the date, and she's working with those individuals. screening for diabetics. We might plug in July. We're working with one of our facilitators from UK, so also he might be part of the education. So we're trying to line up those dates, because during the week, sometimes these experts have to have their dates already set up. So it's hard sometimes to get them lined up. So as soon as we do, even if it's between meetings, I can just post those days, and then so we know. And then of course, the screening of the diabetic and then neonatal hypoglycemic, that more likely will be in August, according to Dr. Msambichaka and Dr. Akida. Okay, so that's a part of the training. So let's go back to the feedback. As I said, I'm going to repeat again, Dr. Mbinda, thank you very much for your hard work. So I'm going to give you just a update here, and I'm going to review with you what the responses he sent. So we were talking about the representative. We did get Mwimbi and Mwananyamala last meeting. And then so we're hoping Buguruni also will join us some of these meetings, but they always read and provide feedback through after we send the audio. So, but we rather have them here so we can contribute lively and then get that information going. And then so we did ask you for the statistic. Mr. Mbinda came through for us, and I received the information on the 6/12/22, sorry. And then we wanted to know maternal transfer protocols. He did respond by 6/21, so thank you very much. And then of course we wanted to compare the protocol from hospitals and the Ministry of Health. He did respond that 6/21. I have the response in a few minutes. We did ask about the face-to-face meetings. We wanted the number, head count for all the staff that are coming. So all three hospitals, we have the numbers, and I'm going to give it to you. I think I got that response yesterday from Mr. Mbinda. And then Dr. Akida, again, she did send me the information from Mwananyamala. Thank you very much. Mr. Otavi, also, we were asking about the numbers from Wimbili. He was going to send that number, also the names of the people who are going to attend the class to Mr. Mbinda, and I believe Mr. Mbinda was working on it. So I'm only waiting for Mwimbili, and of course the Buguruni, the names also we need. Oh, that's from Buguruni. Thank you, Jesus. Mr. Bashiri is coming in. And then all our goal, because we want interdisciplinary training, and that's why we want all those three hospitals to provide names. So when we come and train, we want to train almost everybody so they can have the same information. So we do appreciate the support and the collaboration between all those three hospitals and the Ministry of Health for sending their representative to come and help us logistically to plan this effective training. So it's going to be an exciting part that we're going to have all the training in one area for the first week. So it's going to be exciting. I can't wait. But so let's go back to the report what Mr. Mbinda said from those things. Mr. Mbinda, do you want to go over this, or you want me to go over it?
You can continue, doctor. Yes, I can hear you. You can continue, but continue.
Okay, so I'm going to go it, and if there's anything that you need to jump in, let me know, okay?
Almost, let me do it in summary. The data which I've already represented here is coming from the Health Strategic Plan 5. That's current that we are using most of the data. So sometimes we do not have much research that have been done in this area. So if you move to some of these, they say 25, 33. So when I started with my director, we decided to use the Health Strategic Plan 5 currently, which we are going through, which we are using now as a country plan for in terms of the health matters. So some of others, I think they will be doubting some of the data. The example of the issue of maternal, some of the literature, it's saying it's 500, others is 433. And if you come to issue of neonatal mortality, others they say 25, others 37, others 43. So all the data which are here, I've taken it from the Health Strategic Plan, and I think I've shared it with you. Dr. Agbon?
Yes, I can hear you, yes.
Yes, I did share it with you, the strategic plan. I think you have seen it.
Yes. So yeah, then, so go ahead.
Yes, I just want to elaborate that the source of the data, where does it come from?
So you said the health statistic what?
Health Strategic Plan 5.
Oh, strategic. Okay.
Yes, Health Strategic Plan. It's called HHSP 5. I've already sent it through WhatsApp. I shared it with you.
Okay.
Yeah. That's
Yeah, so just to comment on the newborn indicators. So to me, if I see neonatal mortality rate is 43 out of 1,000. Yes, that number. Yeah, but those are 43 babies who maybe we could have saved some of them, or it'd be nice if we can save all of them. So that's the part which we find out. So of course, each hospital is gonna have it's a different number because of the range and the number of the babies who are born at that hospital and then the criteria that they're using. So yeah, so one hospital might have 25 out of 1,000, and another hospital might be 65 out of 1,000. So then if you equal them up, you might get the average of 43 out of 1,000. So we have a lot of work to do. We have one baby is too many. Yes. The same thing for maternal mortality. 432, whether it's 500 is 400, that's close to almost 50%. That is acceptable. That is.
That's what I was going to ask you, Harriet, if I was reading that right.
That is not acceptable.
432 out of 1,000 mothers.
Yes, so that's like almost 43.
Okay, I wasn't sure if I was seeing that.
So remember we were talking about a 50% survival rate. Was that just for the mothers, or
just for the mother for postpartum hemorrhage? Yeah. So that's it. I mean, that's a huge number. We do need to cut down to that number by identifying those things that leads them to losing their life. That's too many baby moms to die for maternal mortality. And then so for the low birth rate, yes, it's 9.1. You might look that number is very small, but that's too many. If one baby dies because of just to have the low weight without maybe other complications or abnormalities, that's too many babies to die. So there are a lot of stuff. I mean, this statistic, thank you for giving a statistic. We know where we are starting from. I mean, there's more things underneath we need to figure it out. But at least if we have a number like that, so it's easier to logistical and planning purposes, easier to break that number and be able to drive and try to address some of those risk factors. So if they are modifiable, then we can try and play around with that modifiable factors so we can reduce that number, definitely. And then in mortality under 5, that's 71. That's too many kids dying. We need to be able to chip away. Is it because maybe the leash, we would say nutrition, and then yeah, so there's a lot of stuff that we have to address, and the type of the food, because these kids are growing so fast. We need some nutritional food, not just on a pure carbohydrates. So there's a lot of stuff that we can chip away from it to try and address that mortality. And some of them might be things that the child was born premature, and then there's a lot of things that were not addressed then. And then of course, added to the complication, the child end up dying before even the age of 5. So each one of them might take a while to be able to figure it out, but once we figure it out, we have to start addressing those risk factor or modifiable risk factor. Those are the things, and I believe, I mean, there's a lot of them I think that we can address. There's some of them probably might have to take a little bit longer than a year or two to start to working on them, but we will have to do that because those numbers are too high. It doesn't matter how we look at it; those are numbers too high. So thank you very much for even giving us a little window of what we need to start working on. And it makes sense for us to know if we start targeting one thing at a time, then we can say we have this number in front of us, we need to start lowering that number. And that is a great start. So thank you.
Okay, thank you, Dr. Giboni.
Yeah, you're welcome. And then for the next one, for the protocols, I know you said Mwananyamala and Buguruni are the ones that are transferring the babies from their hospital because they're level 1 and 2 to Muhimbili, but Muhimbili does not have the referral because they're receiving it. But my question is, even if they're receiving it, they have to have criteria of like, this baby comes to us with this, this, and this, and this. If they have those criteria, we need those criteria because we need, when we're teaching level 1 and 2, we're teaching Buguruni and Mwananyamala to transfer those babies. We need to know what the receiving hospital is expecting so we can try to get that level of care while you're transferring that sick patient to them. So we have to have the referral receiving, I mean, I think there's another word, I don't remember, but they have to have a protocol that they're accepting criteria. Like from a doctor from Buguruni, sorry, call Muhimbili, we are transferring this baby with this and this and this. Muhimbili have to say that that baby have A, B, C, D, CPAP, whatever. I mean, IV, medication, x-rays, I mean, all those things have to have that. So they need to know if you're accepting this child, the child needs to meet this criteria in order to maintain that child to arrive in that hospital. I mean, in a better shape so they can continue saving the patient's life. If the Muhimbili does not have the criteria of receiving those babies, so then when the Mwananyamala or Buguruni is transferring that baby, what are they basing their care for? I mean, like, which are they gauging the patients to see if Muhimbili expect the child to have x-rays, antibiotics, whatever. If Mwananyamala does not know that, they might not know to do x-rays to try and see, or they might not know to intubate the child to try and, or they might not know to start giving blood to that mom who has postpartum hemorrhage going to Muhimbili. So we do need to revisit that part to find out what the criteria that they are accepting these babies. I'm sure they should have something to be able to say, okay, this type of patient is going to come to us. This type of patient, maybe not. So if we know that, then it will be easier for us when we are working with Mwananyamala and Buguruni to prepare them or to enhance what they have now to say, okay, when you're sending a child, mom to Muhimbili, that child needs to be at this stage, at this level, this level of care to transfer them. And then, so then at least we make sure when the child or mom gets to Muhimbili, that child arrive there in a better position to be helped in Muhimbili versus in be more compromised or in trouble to get to Muhimbili, and then Muhimbili cannot do anything else, and Muhimbili end up with a statistic that somebody died in the hospital, but they could not even do anything to save that patient anyway because the patient did not come at the same level that they're expecting that patient to come. So those, I think that we need to address that part. I don't know, do we have any representative from Muhimbili right now?
Yes, I think a representative from Mumbai will be helpful. From what I know, the way which they make the nanny transferring that baby, if they have the baby who is having a certain problem, from Mwananyamala maybe, the people from Mwananyamala, they have to call Muhimbili first, that we are transferring a certain baby with a certain conditions. Yes, what I think that's what they do. But for the issue of protocol from Muhimbili, I'm not sure, but if we have Jafari from Muhimbili could help us for follow up on that, the person who is working at Muhimbili, it will be easier and better.
Yes, and I think, yeah, I mean, I agree with you that yes, Mwananyamala will, I mean, do have the, I mean, so it does have the protocol to transfer the patient, and Buguruni does have that because I've seen those, they've forwarded them to us. I understand. So those are how they prepare the patient to transfer to Muhimbili, which is fine. But Muhimbili should have receiving, like, okay, these are the baby criteria. So when we refer them, let's say the doctor from Buguruni call them and say, I'm going to transfer this baby with A, B, C, D. Muhimbili might say, that baby is not going to make it, incompatible with life. There's no need to transfer, give them supportive care. They have to have something that they may accept the patient or may not accept the patient. So all those things have to be addressed. Okay, so yeah, so we're gonna try to Mr. Jafari or Dr. Mushiro for the NICU part, so we can ask them, or Dr. I think Mulungu for the anesthesiologist, because they do trauma patients and stuff, they receive those patients. So that may give us a little window of what expectations they have for patient who is arriving to them. Do they need to have like a CPAP? Do they need to be intubated? Do they need to have blood on board? Do they need to have whatever? We need to know that. So when we're doing training for for Mwananyamala and Buguruni, we can address those things. And then also the transport team also should be up to par for whatever they're attending this person, because this person is already sicker than normal. So they require a higher level of care. We need to be able to give them during the transport. So that is going to be another section of discussion. So thank you again, Mr. Binda. I think you added standard referral protocols for Muhimbili. You give them there. Part of it, I think they are saying if the babies, yeah, so this is the same thing that we were talking about. If the Muhimbili or Mwananyamala transferring the baby to, Buguruni and Mwananyamala transferring the baby to Muhimbili, yes, baby with 1 kg, or the baby who is less than 30 weeks. So then, yeah, so that's the criteria for this hospital to transfer to Muhimbili. But then also that baby needs certain care on transit to Muhimbili that also is something that Mumbai is expecting, or to accept the patient with those part of care. So we need to know so that we can match what exactly Mumbai is expecting. And then so we can, so severe respiratory distress, it has to spell out exactly what it is, how much oxygen this baby have, whatever the level of care, because the severe respiratory distress might be interpreted, it might be a loose definition for it if we don't define. And so wherever they have listed as severe respiratory distress, we have to have those criteria objectively measured. So, I mean, mentioned, so we can make sure that everybody's objective to that area. So we don't miss the babies, we don't keep the baby longer than necessary, we don't keep the mom longer than necessary when we need to transfer them or make that decision. But I remember, I think Mr. Bashir Mari, one of the meeting we discussed when we were talking about the transport to patients for postpartum hemorrhage, I think they have too many patients who are transferring with that. So then we say, what are the challenges for transport? And I believe he mentioned that the delay of making that decision. So identify the patient is in trouble and then calling for referral and then accepting the patients and then send that patient. That time, if it's too long, somebody who is bleeding does not have that much time. So if we use from identification to transfer is more than half an hour, for example, that patient has been bleeding for 30 minutes and then they're going to continue bleeding for the next 30 minutes when they have to be on transport. So that's an hour. For somebody who is bleeding, they don't have that much time. However, if somebody has identified that patient and then within 10 minutes, 5 minutes, 15 minutes, whatever the criteria is, the patient has, the decision has been made and then the referral hospital is notified and then they're going to say, give this medication, give this blood, this on the patient is coming, or bring the patient over here. Or what have you tried? And then it fails, then, okay, do this and then transport that patient. So we have to be able to spell them out to make sure that identification to decision and referral and transfer is shortened as much as we can, versus taking your time. One doctor makes the decision, talk to the second and third and fourth doctors, and then make the decision, and then start calling the referral hospital an hour later. The patient is not going to wait for bleeding. If the baby has respiratory issues, an hour is too long. 10 minutes is too long if we don't take care of that baby. And I know there's criteria, congenital abnormalities, that's fine. If there's one of those, defect and stuff. So if they didn't know before the transfer, now they identify at the delivery. So those are the things that, okay, so what do we need to do? So there's a care, okay, now the baby has a neurotube defect right then and there, and they're gonna require transfer. So there's a care that you need to do right now before you transfer that baby. Do we protect that site? What position do you put the baby? What are the things that you need to make sure the baby has hydration, whatever, maintain temperature, glucose? All those things have to be spelled out to make sure whoever is knowing that baby is transferring, they need to prepare that baby. And then so these things have to be sent out. So, I mean, there's a lot of stuff that we can work on. Yes, I agree that it's listed right here, but we have to have almost like a SOP next to it, standard of practice, to say, okay, neurotube defect have to have this and this and this and this and this. The care, intervention-wise, as nurses, I want to be able to see, okay, you give them the diagnosis of the neurotube defect, I see that right at delivery, then I need to do A, B, C, D. It has to be as objective as it can be. It does not have to rely on my experience or clinical practice to say, yes, I'm going to do this. Oh, what should I do with a neurotube defect? No, it should not be a question of asking at all. It should be spelled out right then and there. But as I said, we're going to work with them to make sure we know for sure. Congenital heart disease, criteria, vital signs, what parameter that baby needs to keep, be able to do that. So, I mean, there's so many things that we can work, and I'm glad that they identify there in the list. So that's great. And I know you said they do not, I mean, not for all those congenital anomalies, if they're incompatible with life, then yes, there's no need to transport. You mentioned that if the patient, the baby has a gastroschisis in the abdominal content more than 2/3. So who knows how to measure those 2/3 versus 1/3? So it has to be objectified there also, so nobody's making the decision that could impact that baby's life. So as I said, all those things we are talking about here, it has to be objectifying, like spell out. Oh, Mr. Jafar is coming in. I'm going to give him a chance in a few minutes. Let him get here first. Okay, so then another thing that you mentioned, treatment failure also might warrant to transfer these babies. So then, yeah, so if you failure for responding to second line antibiotics. So So do they, how much time? So those things also have to be objectified. So maybe first line of defense, first line of antibiotics, when do we give the medication? What are the criteria that baby fails? Like, what do you define failure? Like, is it baby still continues dropping the temperature? Baby cannot keep up their thermoregulation. Baby becomes hypoglycemic. Baby's lethargic. I mean, we have to spell it out to make sure there is no ambiguity when you're discussing antibiotic is working, and how long can we wait for this baby? Did we get the right diagnosis from the beginning? So yes, there's junior doctors, there's senior doctors who is making that decision. Did we consider everything else? So if everything is spelled out, it's easier for the doctors to make the decision, and then you just almost like follow like a little tree to say, this is met, this is met, this is not met. Okay, now we need to start thinking transport. And if you're thinking of transport, okay, the baby has a line, baby has a whatever you feel, and now we're gonna transfer this, baby's intubated, baby's, all those things needs to be, people be thinking, not to wait until the second antibiotic is not working, which I don't know how long or how far in between, making the decision that being 5 hours later, 6 hours later, or the next day, I don't know. So we need to make sure all those objective as much as we can to help the junior doctors and the senior doctors to have the same level of care at the moment when they're making that decision. Phototherapy. So phototherapy, the same thing. If we have phototherapy, do we have enough, first of all, phototherapy devices? Oh, sorry, typos. Phototherapy devices to capture all the babies that need it. Did we keep that baby long enough to the phototherapy to make sure, okay, is it working or is not? Is the baby eating? Is the baby maintaining the temperature? You know, all those things. With phototherapy, you expose the baby. What other things that could impair the hydration? You know, like baby peeing, is baby peeing enough or whatever? All those things have to be done. We check the diet combs and see what other factors. So, I mean, there's so many things that, as I said, we have to spell it out to make sure everybody knows what he's talking about. And then, of course, hyper and hypoglycemic, I mean, that's one of the topics we're going to cover with Dr. Msambichak and Dr. Akida. Okay, so whatever the kind of hypoglycemia care or protocols, okay, so how can we address it? Do we have enough staff to cover that part? Because, yeah, we can have something written on the paper, but it's not applicable because you have one nurse with 30 babies or one nurse with 60 babies. How is she going to do that to check the glucose to make sure they catch those baby who is hypoglycemic? So there's so many things that we have to discuss, but we're going to have to address it somehow, somewhere to be able to address those things. Life-threatening, you already mentioned that, but that's good. That's one of the criteria. If they identify the acute kidney injuries, that's fine. The PPH for the babies, that's fine. Hemorrhage, need for life advanced life support, that's fine. If they need intubation and the hospital does not do intubation, that's okay. Then we need to support that baby until the baby get the intubation. So there's a lot of stuff that we have to address, but this is a great start, and I thank you for doing collecting and then bringing it up to us. Conditioning for referrals, that's fine still. What the baby needs to have, what mom needs to have before referral. I mean, I understand the oxygen therapy, what type of it. Blood transfusion, do we have blood in the transport? Because you can have a policy that requires, say, if mom is bleeding too much, they should have blood transfusion. Great, where's the blood? Can they get the blood? How many units should they get before they transfer? How much the mom bled? So kangaroo mother care, do you gonna transfer the baby with mom? Because baby needs a higher level of care, or the mom stays on the original hospital and then baby goes by themselves? I don't know what the answer for that. So it depends. If you transfer mom, is the mom stable enough to transfer with the baby? If with temperature control, the thermoregulation, we already covered that in the theory part. What else do we need to take care of this mom and keep that mom nice and warm, or baby, sorry. And then does the person who is transferring that baby or mom knows how to do CPR? Can they identify the criteria that they need to initiate CPR? Are they trained? Can do that? Can they run their own route to go to there without, while they're maybe consulting with the receiving hospital? So all those things that we have to be able to address that when we're training. And then, so how soon do they get the consultation with the referral? Do they have, everybody knows the number? I believe Bugurun does have the number, and I'm not sure if Dr. Akida probably will help me. Does Mwananyamala also like have the number posted that you everybody will know when we need to transfer? this is the number you call, and then you get the person on the other side accepting that baby or moms on that side to be able to continue care, versus you call, wait until somebody to call you back. I'm not sure about that process. So we're going to find out when we start working on that part. And then I think the last thing, and then I will let you guys discuss all those things I just read back to you. So Minister of Health also does not show the specific, I mean, they do have the transfer part, but they don't have, does not differentiate, sorry, between the adult and child. So, and this was launched 2020. So, which is fine. So at least if they have it, then we have somewhere to start from. And then we have to be able to identify, okay, so if it's mom, can we add ABCD because that's mom? And if it's baby, can we add ABCD to make sure we address the needs of the baby? And of course, for the criteria that was mentioned above requires transport, sorry. Those are things that we need to be able to add the supportive care during the transfer, and that's including the training for people who are escorting that mom or escorting that baby to make sure they know what they're doing and what type of the diagnosis, and then they should have objective things to follow while on route until they get there. So in the last thing that Mr. Mbinda did an excellent job also, we have now Muhimbili, we have 220 nurses, and we have Mwananyamala 95 and have Buguni 35. So those are all nurses. I did not see any name about the doctors. The nurses don't work by themselves. We don't need the
Sorry, doctor. Dr.
Yes.
Gibol.
Yes.
Yes, those, I think from Buguluni and Mwananyamala, that's the total number of nurses and doctors together.
Okay.
But from Muhimbili, I think those are the total number of nurses only.
Okay, okay.
That's why I'm still working on the names. I already forwarded the names from Mwananyamala.
Yes,
I'm still waiting from Bogoloni and the Muhimbili, I think.
So both nurses, okay.
Except from Muhimbili, all nurses. I'm still waiting for the number of doctors.
Okay. So the problem that if we teach nurses and without the doctors, it's not going to work because nurses don't order anything, don't prescribe anything. Yes. Even if we teach them excellent job, they can do it, but the doctor have to order it. So we do need our counterparts to come and help us.
Yes, because we need the continuity of care.
Yes, yes. So
so I think Mr. Jafari will provide us with those names. We build a large number of staff, so compiling them is just a big deal. So I think he'll be finished and he send us to us later after the meeting, I think.
Okay, perfect. And if you can include Dr. Moshiro, because I think he also has been in charge of the NICU part. So he might probably provide more doctors' names also.
Okay. I'll do it. Thank you.
That'll be good. So, I mean, any comment from everybody? Because I mean, I know I was going a little bit faster, but I just want to make sure we can cover what Mr. Mbinda provided for us. And again, thank you very much for doing that. Anybody has any question from that report?
I think more of a comment and just a follow-up. I appreciate the data. I appreciate that that was shared and collected. I think that's one of the first steps is to know where you are so you know where you need to end up. My other question is, moving forward, will we continue to get data after, like, since we're doing the pre-work and then physically being there, that will continue to be reported out?
Yes.
Okay.
Excellent point, because I think with those previous meeting we discussed, once we know the data, we identify finding the possible risk factors that contributing, and then identify modifying factor that we can include in the training. Then we have to get the report either monthly, or I think some of them were saying weekly or every other week. So we can be able to monitor as we go, because we have to be able to know how many people are being taught. And then what other things that once we start teaching them, what are they applying now on the units? Like you said, they're learning about the ventilation, and we go and validate the skill. I'm expecting those skills need to be performed now. And then so how many people have received resuscitation that month, and then how many unfortunately we lost. and how many, like we may not see the change immediately, but at least we still need to capture that data monthly to be able to see if we're going to start having that little nice trend of less loss and then increasing survival. That's what we want. And then so if we start saving those babies and we start getting better care, we are hoping every month we can see the trend. After a year, then you'll be able to see exactly some contribution or some moving of that little dial. It's going to take a while to move it. I mean, if I move by 1% at the end of the year, I'm happy because that 1% would have never had that. It could have been maybe lost for 2%. So whatever. And then after that, we get more people trained and continue increasing the clinical education. So then we're going to probably start seeing impact within 2 to 3 or 4 years. Most of the time, that would be like, if you start now, you're going to start seeing within 5 years. Yes, we have to be patient, but we have to start seeing those little milestones to be able to move it. We can't just say, okay, we're not collecting data, we're going to start in 2 years. It's not going to work because you have to be able to identify every month to see what we are missing, add it to it to see if we can address, because maybe there's something that we did not think of it. So we need to be able to address that and improve that. I'm reading the Dr. Msambichaka's note. It says, if it was babies, I would not be here. It's grown-ups, and yes, they always don't behave, but at least they can talk, which is true. If the mom or the dad is at the hospital, they're getting sicker, they will tell you, or they will scream, or they just acting out. But baby don't do that.
No.
Baby quiet, doesn't want to say anything else. They hope you know what you're doing. If you don't, then they're gonna die. So it's crazy that with baby, that's why we keep insisting and working so hard to try and identify those risk factors that we can fix and help the baby and give them a better chance to transition. Mr. Jafai, I don't know how much you heard when we were discussing about the feedback from Mr. Mbinda. We wanted to know if Muimbi, do you have a protocol or, transfer protocol, like somebody, the level 1, level 2 hospital calls you in Muhimbi to transfer a mom or transfer a baby. Do you have criteria, say, okay, maybe for example, you have to have x-rays, you have to have this, you have to have antibiotics, you have to have this on this baby who you are bringing. Do you have the criteria or something that spell out what exactly that child or mom should have, for postpartum hemorrhage should have for you guys?
Thank you, Dr. Harriet, for this question. And actually in Muimbili, we have a protocol, but it depends on the condition of the baby by meantime. And as we know that when you have a baby who is not okay, so as like I said, that it depends on the condition of the baby. Like the baby who had beta asphyxia, so you have to make sure that at least when you come with that baby, you have to maintain the warmth of the baby, and also you have to resuscitate the baby throughout when you come, or you have to stabilize the baby before transferring to our hospital. But also that protocol is there, and we shared with them as we based on our national NATO guideline, and we go so far on dissemination of it, especially in these regional referral hospitals, which we are actually receiving most of the cases from these hospitals, and we tried so much to at least to equip them in knowledge. And we have a project as well which is still running, and we thank God that through these projects they have some equipment that they can also care the baby at the hospital. But in case of the cases which are not comfortable with them, then they refer to us. But the protocol is there, and they know.
Okay, no, thank you very much. So when we are trying to work with Mwananyamala and Buguruni, then so yeah, we're gonna need to be able to compare and match of you with your protocol to make sure when they're sending these moms and this baby, they meet what you expect that baby to have during transfer, or they meet or expect for you the baby and mom to have during transfer. So we would need those protocols to be able to make sure if we are teaching them something in Buguruni, it should match what you expect to have, because we don't want to teach something that you guys don't expect, and then that is not, we're not going to measure anything there. We want to make sure whatever you expect for a baby to have during transport, it's been done either from Buguruni or Mwananyamala. So we'll need to work on those, the protocol. Did you send me that protocol or no?
And actually not yet. For neonate, I think I will try to discuss with Dr. Moshiro because he's head of department of that.
Okay.
So I think he will provide it.
Okay, perfect. Thank you. Any questions, guys?
Dr. Gubani,
Yes.
I do have a question. So regarding the protocols, are all 30 hospitals aware of the same protocol?
No.
Or no?
Because every hospital has their own, because they are in a different level. So there's level 1, level 2, level 3. So level 1 have a certain level of care they can do. I'm just giving an example. They might not be intubation, they just do supportive care, you know, the nasal cane, you know, the bag, mask, or whatever. If the baby or mom needs care more than that, then they have to go to level 3. It depends on where they send the child or the mom. So their protocol might be a little bit different. We are trying to get, at least that protocol should be written in phases. So can apply for level 1, level 2, level 3. Means like if you're level 1, you do the first part. If you're level 2, you do first part and a first phase and second phase because you're level 2. And level 3, usually you do all 3 things. So that's the part which we need to, because the level 1 needs to know what level 2 expects about their transfer. And needs to know level 3 what they expect, so I can prepare that patient for what the level 3 or level 2 expect that baby to be. And that's what we're trying to do. It has to marry each other to make sure that everybody knows what you need to do. Because otherwise, level 1 might prepare this patient, and then Muhimbi has no idea what you're bringing. And Muhimbi is going to be on the disadvantage because they're going to receive the child who is not ready for their resuscitation and stuff, or the child is more compromised than expected, and then the child is going to die in Muhimbi, and it looks like baby died in Muhimbi. But they didn't have any chance to save that baby's life because the baby got there already way compromised and they can resuscitate. If Muhimbili expect to have the baby with A, B, C, D, and level 1 Buguruni is transferring that baby, preparing to match those levels, that will help and give the Muhimbili a better chance to resuscitate that baby, or mom for that matter. So that's the part we want them to talk to each other and make sure we know who offers what and who doesn't, and if they don't, what best way to do to sustain the baby or the mom during the transport.
Yeah, that was my question. So they don't do that right now. They're not aware of one another's protocols, correct?
As far as I know, I'm not sure that if everybody knows what is what, but I'm sure if they have their own protocol, they're doing their care right now with the protocol that they have now. Does it match to other hospital? I'm not sure, but we're gonna find out by working with them and try to make sure we streamline the transfer process, so at least we know what is going on.
Sorry, Doctor.
Hi, Dr. Akide.
The transferring protocol is almost similar to the regional referral hospitals in Dar es Salaam, because these protocols that I sent to Mr. Mbinda was introduced in 2015, if I'm not mistaken. We had the meeting with all regional referral hospitals in making these protocols for referral to MNH. So I think they are similar to all regional referral hospitals in Dar es Salaam.
So when you say the regional referral hospitals, is Mwananyamala referral hospital?
Yes, Mwananyamala, Temeke, and Amana.
So Buguruni is not?
Buguruni is not. And when we discussed about this regional referral hospitals protocol, the one which was responsible was CCBRT. And currently we are working with the NEST, the Ifakala Health Institute. We usually preparing the SOPs to newborn treatment. Before it was CCBRT hospital.
Okay. So then, no, thank you for sharing that, but that at least it helps us to understand. So all the regional referral hospital have the similar protocol, which is great. However, you are getting a child or mom from the level 1 or health centers or like a Buguruni. So that's what we want to know, because I know Buguruni have their own, but I'm not sure if Buguruni follow the regional one or they have their own for their own level. And that's the part which we want to see if regional, referral, and the health center or level 1 hospital have similar things. So then when the Buguruni is transferring the patient to your level, they should have matched at least some of the things that you guys expect the patients to have when they arrive to your hospital. That's what we're trying to make sure you have in the list. Mr. Bashir, I see you are raising your hand, and Mr. Bashir is from Buguruni. Go ahead.
Dr. Harry, hear me?
Yes, I can hear you. Thank you.
Okay, thank you. Actually, in referral protocol, in level 1 hospital as Buguruni, and as well as I have experience, I was already working to another hospital, which is level 1. We don't have a referral protocol for neonate and the maternal referrals. But the referrals depend upon the condition and the problem of the neonate or the mothers. With the PPH, we can manage and prepare for referral according to the problem which have neonate or the mothers. If neonate, maybe like base asphyxia or aspiration pneumonia or whatever, the referral protocols as we are performing depend upon the condition of the baby or condition of the mother. So we don't have the real referral protocol until now. Thank you.
Okay, no, excellent. And thank you for clarifying that, but that helps quite a bit because that's what I'm saying. If whatever you guys are doing right now, we want to make sure we give a chance to prepare that patient to send it to referral. So at least the patient is going to get a better chance because you know what the referral hospital is expecting with the child. And I know probably, yeah, you might not have what exactly they do, but at least that patient, when they're going or they're en route, they should have something that will help to get there. Dr. Akira, did you raise your hands?
Yeah, we got 2 raised.
Yes.
Yes, go ahead.
Okay, I don't know about Buguruni because Buguruni is in Ilala municipality in which the Amana hospital is in charge of it.
Okay.
But the hospitals which are referring to our hospital usually have the outreach program in which we spread all the SOPs and the referral protocols to these hospitals which are referring patients to our hospital.
Okay.
The
Yeah,
protocols are
I'm sorry, go ahead.
the protocols are the same to the hospitals which are referring patients to our hospital because we usually do outreach to these hospitals.
Okay.
But I don't know Buguruni because it is under Amana Regional Referral Hospitals, which is in Ilala municipality.
Okay, Ilala, okay. Okay, so that makes that makes even sense because then it's gonna go to regional areas, those protocols. And so we, at least we give us an idea of like, maybe we should find out what Amana expects. And then to see when we're doing the training, then yes, to matches. But I know, correct me if I'm wrong, I know Buguruni and Mwananyamala, if both of you guys need to transfer a patient to Muhimbili, you both send to Muhimbili, and Buguruni can send it from wherever they are to straight to Muhimbili, right? Right, Mr. Bashir?
Yeah, you're right.
Okay, so then you still have to make sure this protocol, we don't have to change the protocol to like E1. If we could, it'd be nice. But we still have to make at least similar things, similar basic life support therapies we need to be doing everywhere, each hospital. It doesn't matter which region you are in. So, but still, we need to make sure those basic things are there for person who is going to escort that patient, mom or baby, to have during the transport. So that's good to know, but so we still need to make sure they're covered that way. So good, thank you, thank you. Mr. Bashir, did you have something else or your hand is up?
Yeah, no, thank you.
Okay, so thank you very much for those responses and questions. It helps us to understand. So I'm gonna go to the second part and then we should begin. Hi, Dr. Benel. I'm gonna share my screen for a second. Okay, so today's agenda, we're going to add what Mr. Raymond's clinical experience with transferring patients from multiple locations. the role of the staff person who is transferring, either EMT versus paramedics or versus the nurse, and his clinical experience, just to give us a little window of usually what exactly the expectation is as a transfer person, or you guys are in Tanzania said escorting person, does during the transport. So I'm gonna welcome Mr. Raymond here. Oops, I need to stop. There you go.
Hi, y'all. So, yeah, I do inter-facility transfers in Virginia. I work on the ambulance as an EMT. So I guess today we're just talking about how we're going to transport patients in Tanzania from different roles of hospital to a higher level, and just we're just outlining basically the protocol I would do, right?
Yes.
Okay, so when you get to the receiving hospital, usually there's already a transfer of information from the lower role hospital to the higher role hospital. So the higher role hospital should already have information on the patient, including like CAT scans or x-rays, whatever tests were done and their results, and that should already be at the higher role hospital before transfer is even initiated, at least here in Virginia. And then when I get to the patient in the hospital, there's usually a set of vital signs and a packet that comes with me as a secondary way to ensure that that information gets there. So that packet has all their vital signs, anything that occurred in the hospital, and they were primarily taken to the hospital. And so that's just to make sure that if the transfer isn't done, the information transfer isn't done correctly from the lower role to the higher role, that there's still the information with me so that I can know that the other hospital has all the patient's information. And then, of course, we want the patient to be stable, but if they're not stable and it's just a transfer that has to be done, then we'll take them while they're not stabilized and do our best to keep them stable. But with that comes knowing the levels of transport. So I'm an EMT basic, and then there's EMT intermediate, advanced, and paramedic. So the nurses should be aware of what level of transport they need. So an EMT basic isn't going to if a patient's on a vent, an EMT basic is not going to be able to run that vent for you. They're not capable of doing it. They're not taught. So that will require a paramedic or an AEMT. So the hospital needs to know that. I don't know if that's a problem that's occurring in Tanzania, sending patients with an insufficient level of care, but that's very important to know when you're transferring a patient so that they're able to get the level of care that they need. And then I remember last meeting, we were talking about RNs riding for these postpartum hemorrhage mothers. And, that's really good. We don't usually have that in the US. It's usually just a paramedic, but having an RN would be ideal to be able to deal with the issues the patient is having. But so I also read the package you sent me about transfer protocols, and I see the common issues they listed out here. Issues with communications between the hospitals and the transport team, and issues with hospital communication. So once we get in the truck or the ambulance, the patient immediately gets a set. The protocol is there's a time for each set of vital signs taken depending on the issue. So for a patient who would be experiencing postpartum hemorrhage, that would be every 5 minutes there would have to be vital signs taken, and it's charted and it's put in the packet that the hospital gave me during when I first received that patient. So all that information is given to the other hospital. And then the paramedic who I'll be riding with in that situation would be, administering TXA and fluids, blood if we were giving blood at the time, and the amount of blood and all that stuff that was given to the patient will also be included in that packet to ensure that everything in the hospital and on the ambulance that was given to the patient and done is given to the next hospital. And so while we're riding and we're doing that, trying to keep the patient stable, we have Medcom, which is the radio network we use to communicate between ambulances and hospital. So between 10 to 15 minutes before you arrive at the hospital, whenever you have free hands, basically within that 10 to 15 minute window, we radio to the receiving hospital with the information of that packet. Not all the information, but the vital signs we've done on the truck and interventions we've done in the ambulance, so that the hospital knows the condition of the patient they're receiving. And I don't know if they're doing that in Tanzania either between their roles of hospital, because it seemed like an issue that I was listening to the packet, communication between the ambulance and the hospital. But it ensures that the patient, like they know the current condition of the patient, not the patient when they left the hospital, because it usually changes once you get out of that, sterile, still environment of the hospital. And once you're in the ambulance, things change. The patient tends to, have a decline, but hopefully, you keep them as stable as possible. And then once you get to the hospital, they have that already, that current set of vital signs. So they're able to go to work immediately. And then also in that radio call, there's the cause of the issue. So if it's postpartum hemorrhage, I would say they're experiencing postpartum hemorrhage. So when I get to the hospital, the receiving facility, there's usually already a specialist or a nurse who's ready to deal with that specific issue. So I guess in the case of postpartum hemorrhage, that would be a gynecologist. So that would already be ready to go. Like I wouldn't be sending the patient and then a nurse is already like trying to determine the issue, or a nurse is trying to figure out what's going wrong or taking another set of vital signs, because I already did. So they're already getting the intervention that they need. Yeah, and that would basically cover how we do our interfacility transports.
Thank you very much, Mr. Raymond, for sharing that your experience at the transport. So you can see how the communication between one level to the next will ensure the safety of that patient, because what Mr. Raymond was just saying, he received the patients, get the report, and then get the patient in the ambulance. He needs to do whatever he needs to do in the ambulance while documenting and continue monitoring the patient. And then he has to radio them before he arrived. So the nurses, the SBA. So you tell them what exactly is happening. So they're waiting for you. So as soon as you get there, there's no more, so okay, now tell us what happened, because you're wasting time. So by then they're waiting for you to, okay, come in, maybe you come and bay whatever the patient is gonna be for, whatever, it's gonna be ready for that patient, or go straight to the room, whatever. So there's no that waste time, okay, let's wait and let's get the paperwork. And I'm thinking one thing he's mentioned, that before the patient is leaving the hospital, then the information has been sent already. So the referral hospital has already received that information. So they already start reviewing it, and they might update him en route if he needs something to be able to say. Let's say maybe medication was missed or was not given. Oh, did you give this? No, okay, give it while the patient is en route. So that's the part of the communication we want to try to make sure this protocol talk to each other to a point that the person who is transferring this patient is aware and informing you as much as you can before that patient arrives to the receiving hospital. So when the receiving hospital, that got patient is almost, there's no disconnection. It's just continuation from one hospital to the next. The patient is being maintained. So chances is the survival for that patient increases, because somebody is watching that patient, and somebody with a higher level of care from the receiving hospital is aware what is happening to that patient who is coming. And then if there's any issues, it might say, okay, give this, start that when you're coming. And that equipment, the ambulance should be ready to go with those things. And that's why I said, if the protocols are there, everybody knows what are the basic things that they should be in the ambulance. If the protocol does not talk to each other, chances is you're not going to prepare that patient adequately. And then things are going to be, by the time the receiving hospital is getting that patient, the patient is more compromised, and chances of survival decreases immediately as soon as the patient hit the ambulance. So that was an excellent presentation, Mr. Raymond. Anybody has a question for Mr. Raymond? Because I have a few for Mr. Jafari, Mr. Bashir, and Dr. Akide and Dr. Benir. Anybody has a question for Mr. Raymond? Comment? Or you want him to come to work to Tanzania? Any questions?
Actually, it's good to hear from Mr. Raymond. What they did is the perfect thing, and we also like to be like the way you guys doing there. Is actually the process is so smooth, and it's even reduced those delayment in management of these newborn as well. So actually, when we share the ideas on how you practice there, and if you have a chance to adopt that, that would be so nice. So congratulate you for that. Thank you.
Yeah, we are bringing him for the medical mission. You're gonna see him. He's coming.
Yeah, we're waiting for him.
I was going to say too, we would like to, and I know I say this over and over again, we would like to do a ride along, what they call a ride along, where we actually go through the process with your transportation services, kind of like to observe it. And Raymond actually is an EMT, and there's another gentleman who's coming, even though he's going to be doing more of like optometry and stuff like that, but he is also an EMT driver and familiar with the procedures and stuff like that. So if we can, we would like to ride along. And you know, our goal is really just to make things better, you know, and try to find solutions. So if that's possible, if you can help us with that, we would love to do that as well.
I think also the best person to do that is Dr. Benella and Mr. Bashir, because they are the ones who will be transferring patients. I mean, their hospitals, transferring patients to Muhimbili. So we can work with Dr. Benella and Mr. Bashir and Dr. Dina Komakoma. So those are the ones, because that's where the transfer starts from. So then you're having Mr. Raymond and whoever the global volunteer is going to be added there. It will help to give him the wind of what exactly is happening as it happens. And then so he can provide some feedback and stuff, definitely. Because we all want to learn what is working for you guys right now. And then come and be able to say, okay, this work or this might not work. Okay, so if it's not working, then how can we maintain the patient's safety by using A, B, C, D? So that's what we want. Of course, eventually, if we have a lot of money, someday we will, we hope. So we would say, okay, here's the ambulance. This is how things should be in the ambulance. And this is how you transfer the patient, because we all want the patient to get there and be safe and alive, at least. So definitely during the medical mission, as I said, we're going to talk a little bit more. And then Mr. Raymond is going to get that chance to be able to do at least right around in the beginning and then give us the feedback, hopefully have that conversation between those three hospitals and be able to try and mesh those things together and as much as we can while we are maintaining the level of acuity or level of care for each hospital. And then if there's something that we can supplement or add to it during those transport, we'll try to work as hard as we can to make sure you guys get it. So that was an excellent, thank you, Mr. Jafari. Mr. Mbina, do you have any questions, comments for Mr. Raymond? Or Dr. Benella? Dr. Akida?
Can I ask a question?
Yes, please, go ahead.
It's not related to transportation, I'm sorry.
No, that's fine.
I've kind of been in and out listening, but I'll listen to the entire video after, like the entire conversation after. My question is just from a planning standpoint. I know today was focused on transportation, but from a planning standpoint, next time we meet, can we at least firm up like exact number of people? Actually, more, I guess it's a comment, not a question. Firm up the exact number of people that we will be training, at least think of, and this is more towards Mr. Jafari and the team on the ground, Madam Zuhura, exact number of people that will be attending the training session, how many sessions per day, like how many participants per day, so that we can at least firm up, you know, like how many days total do we think we need? We're getting close, and I think just from a logistic planning standpoint, that would be my request selfishly from the Helping Babies Breathe part.
Yes, so we're waiting for one more thing. So right now, as of now, we have 220 Muhimbili, but they're all nurses. And I asked them, I need doctors in there. Mwananyamala and Buguruni, sorry, Mwananyamala is 95, including nurses and doctors. Buguruni is 35, including nurses and doctors. So we wanted that number from Muhimbili for the doctors, so we can include them, because nurses are not going to work by themselves. We need the doctors so they'll be able to prescribe or order whatever needs to be done during those training and stuff. So once we have that, right now we have 350. So more likely the number is going to grow a little bit when we add doctors from Muhimbili. And then yes, so we have those the first 4 days for training at Muhimbili. Then we're going to map them up according to the topics and stuff. And then definitely possible for next meeting. And I think that's on my agenda. Next meeting, we're going to give a pretty tentative schedule to try and see how many people can be done in a day.
In a day, yeah.
Yes, and then using the global volunteer, so we can map up and see how many we need for day, how many nurses and doctors. And then I like what they sent me so far for Manayama and Buguruni, like the nurses' names and in individual units. That helps me to be able to say, okay, if it's like a postpartum hemorrhage, I have this postpartum labor and delivery nurses versus the antepartum. And then so we can map them up to know how many, like 10 or 15 or whatever for this session. So that helps me the way they break it down. So once we get for the, I think Mr. Jafari sent me yesterday the scanned copy for Muhimbili. So we only need the doctors for Muhimbili so we can map up, because we want to make sure we're not going to have like maybe the whole session for doctors. No, we have to break them out because every session should have a doctors and nurses because the roles are different. If we're trying to talk about the resuscitation and stuff, we need to have an actual doctor ordering stuff or running the codes or whatever, versus a nurse pretending to be a doctor. I mean, we've done that before, but we want to make sure it's as real as possible by having an actual person who's experienced with that role, perform that role when we're doing it. So that's why I needed the doctors' names to be able to break them out. And so of course, for staffing purposes, also is going to help if we have maybe 3 doctors in each session versus 15 doctors in one session. More like you're not going to get the 15 doctors in one session because they have to go and work. The same thing for nurses. You're not going to have 30, 50 nurses in one session. We have to break them up. So that's why once I get the doctors from Wimbili, that'll be, we're going to play around to, we're aiming for next week to have that tentative schedule. It might still probably change but from the feedback, but at least we can have a little map up for those 4 heavy week days in the first week to make sure we address as much as we can and get all the volunteers needed for those areas.
Okay, yeah, that's excellent, because I was thinking the same thing. It's like from I'm not sure how, you know, from a scheduling standpoint, I'm not sure how far in advance these schedules are made for the providers. So if we have a tentative agenda, then the different institutions can actually decide who to schedule for training on what day. And then also we would need to reserve the local facilitators, because if you remember from Dr. And it's not Dr. Mr. Saturini,
yes,
some of the facilitators are not in Dar es Salaam.
Yes.
They're from out of town. So if they will have to come into town for this, they need advance notice so that they can block their calendars. And if they would not be able to come into town, then we need a firm number of how many local facilitators in Dar es Salaam are available versus those of us that will be going.
Yes.
I think once we know the number of participants per day, and if, you know, firm it up whether it's going to be 1 session a day or 2 sessions a day. I just thought I would chime in because I have to log out, but I thank you everybody that's been actively participating. I promise I will listen to this and chime in at the very end. Thank you so much, everybody. Bye.
And thank you, Dr. Msambichaka. Yes. Yeah, definitely. We do want those head count, and we did promise by the end of the month to make sure we have that tentative schedule. So people need to know where they're going, including not only the healthcare workers, but also the global volunteers, because they need to know where they're going to be needed in different, and those usually is going to contribute to those invitation letters. Now everybody's going to get one. We're working on it. So by the time next week, people at least we have an idea. Oh, so I'm going to be at the hospital this day and that day. It doesn't mean that you're going to be off. If you're off, you're going to be in the hotel on the beach somewhere. No, you'll probably be in the school working. So everybody, so Bree, don't get ideas. Yeah, so everybody's going to be working every single day, but you just need to know which hospital you're going to be or which location you're going to be and what you're going to be. And even the global volunteers are going to be at the hospital helping with the logistic and administrative things. So while the healthcare workers are actually doing the training. So there's a lot of stuff that, as I said, it's going to start coming a little bit more visual and reality after next week, definitely. Okay, so from what we were planning today, and we just want to make sure we can discuss that in the protocols and stuff, and then we had Mr. Raymond just to give us the window of the how usually they run their transports. So anybody has any questions about the logistic stuff that are left? question that we can work on for the next meeting? Anybody? Oh, Dr. Akida, yes, go ahead. Dr. Akida?
Oh, sorry. I have a special request to Mr. Raymond. Maybe if he could share with us the referral protocol that he was presented, and maybe we can do some modification before the medical mission in September.
Modify the protocols that were sent to me?
No. I think whatever you have now, like, do you have anything on like written, like if as an EMT, when you go to pick up the patient, these are things that I need to do, like a list of things, like your checklist or something. Do you have that right now? Or when
I
they're
don't
doing
have it on me
orientation?
right
Yes,
now,
we
but
have.
it exists. Yeah, it's
No, it exists. So yeah, if we can access it, and then we just tweak it to make sure it applies for people in Tanzania, and then we can share. Well, that's what Dr. Akida is asking. So we can share, and then they can try and play around with it and see if it's going to be applicable and stuff. So, and we can still start communicating with them for different meetings, communicating with them to help them run through what things they need, the possible, glitches, so they can try and work on it. By the time you get to the medical mission, at least whatever you have been doing, you can incorporate for what they're doing currently now and make it a little bit better, and then try to run it. You know what I mean? So yeah, if we can find information like that, that would be great.
Yeah.
okay. I'll look at that protocol.
Yes. Yeah, so Dr. Akida, yes, he's going to work on it, and then we're going to share when it becomes available.
Okay. Then.
Okay, any other questions? Mr. Bashir, any questions? Nothing? Mr. Jafari, any questions?
I think I'm okay.
Okay, good, thanks. Mr. Mbinda, any final thoughts? Uh-oh.
I'm okay to.
Okay, no, that's fine. So just to summarize, we just need the names of the doctors from Muhimbili so we can make a tentative schedule, because I'm trying to work on it this weekend. I know Mr. Mbinda always come through for me. And Mr. Jafari have been doing that excellent work. So if we can get the names after I speak to Dr. Mushiro, that would be great. So then I can start playing around with the schedule here. Ms. Maricela and Mr. Bree here, they're gonna help me do that. So we can just itemize to give a possible schedule. And then, as I said, it's gonna change, but after we start getting feedback, yes. And then once we get that list, for the next meeting, we're gonna see if we can get Raymond define the access that protocol, and then we can share if it's sooner than later, that's fine. And then start playing around with it to see if it's applicable for you guys. And then if we have any questions or anything like that, that's fine. We'll connect you with Mr. Raymond, and then you guys can communicate back and forth. We're gonna have probably another meeting on the side to just discuss the transport. So at least you have a little bit more details, specific questions for what exactly it does, and he can run probably through the scenario or something like that. Or if there's any scenario for like a patient with a certain diagnosis you want him to focus on and give an example, that will be helpful, so he can tell you exactly, okay, so if I have this patient, these are the things that exactly I'm doing. Not that you're going to do the same thing, but it's you can mirror other diagnoses for what exactly you want to put in there, which is fine. So that might be helpful probably for the hospitals there, yeah. And then so when we get there, then he can really run through the MAC drills, which is like, actually, if you have that kind of patient, put him in the transport, go with him and see what you guys are doing, and he can offer his suggestions and stuff like that. So that would be good. And I mean, of course, this meeting is recorded, and I'm gonna summarize at the end and then send the video as soon as I can, so people can share and provide feedback. That's it for me. Anybody has any questions, comments, final things, burning questions? No. Okay, thank you very much, everybody. Go and enjoy your Fridays. So we send this information, and then next week, for people in the US, we're gonna have the members meeting. So you're gonna have more information, more updates, and getting more excited. Start packing. Okay, thank you, guys.
Bye-bye.
Yes, Kwairini.
Asante.
Okay, thank you too. Bye.
Okay, bye. Yeah.